the test easy? A good test is not an easy test, right? A good test is not necessarily a hard test, right? A good test could be many things to many people. What did you say? I can give you one answer on the test. C. Yeah, right. You guys already know way more about the test than I do. There you go. Anywho, so we're going to finish up this section here. We only have a couple, like 40 some odd slides to go, and then I will be extra nice to you guys and let you go after this. So that we have an extra, should be about an hour. If that's all it took to get applause from you guys. I don't like the fact that you were so happy about getting out of here early. So. Okay. Anyhow, so let's get through this. Then if you have any questions about whatever drugs you have questions about, we can talk about it then. So we're talking about treatment for HIV. How do you treat HIV? Heart therapy, right? So highly active antiretroviral therapy. Remember how many drugs you're going to use at least to treat that? At least 3, right? What were 2 of those drugs going to be? NRTIs, those are the nucleotide reverse transcriptase inhibitors, and then you have one other drug from a different class, right? So you have 2 NRTIs, tenofovir and tricytidine, 2 of the more common ones, and then you have another one from a different class. What were some of those other classes? Integrase inhibitors, those are kind of the first lines that the NIH.gov is recommending, or the AIDSinfo.gov. What else? So have our protease inhibitors, right? And we also have our non-nucleotide reverse transcriptase inhibitors, right? The NNRTIs. Just kind of confuse things a little bit there. But yeah, the integrase inhibitors are kind of the big ones. They get recommended as kind of the first line therapy. How would you find out if the virus was even susceptible to the drugs themselves? We do our testing on it, right? So similar to how we culture out bacteria, we could either do the genotypic or we could do the phenotypic testing. What was the difference between the two? The genotypic testing was just actually looking at the actual genetic sequence of the virus to see what mutations that it has, and that, referencing that to a database to say, okay, well, based on these mutations, we think it's susceptible to this and resistant to these. The phenotypic testing, how did that differ? Yeah, basically you'd be exposing it to the drugs themselves and actually seeing, basically in vivo sort of, what is the drug actually or what are the virus actually responding to, right? So that can give you much better idea about what the actual susceptibilities are. What's the drawback? Expensive and takes time, right? Genotypic testing can be done a lot more quickly. And in most cases, when you get that new diagnosis, they'll undergo genotypic testing first, while you start them up on an empiric regimen, and then once those results come back, then you kind of go from there, right? So anyway, and again, how do we monitor for the effectiveness of our heart therapy? CD4 count, which tells us what? How good the immune system is sort of staying, how healthy it is, how functional it is, and what else? Viral load tells us what? How active the virus is and actually actively replicating, right? So what should our viral load be if we have good heart therapy on board? Undetectable, right? So we should not be able to detect that. Maybe not specifically 0, but it's below the detection limits for our test, right? So again, there's kind of a difference between those two, but functionally the same. So looking at this, you can see as the CD4 count starts to drop, these patients start to become more susceptible to these opportunistic infections. And so it's important to recognize this, and a lot of times you're monitoring for this, and we'll have what we call primary prophylaxis. And we have secondary prophylaxis, and then the actual treatment for the infections themselves once they actually occur. So the primary prophylaxis is what you would give once they get down below a certain threshold of their CD4 count in order to help prevent the infection from occurring in the first place. What do you think secondary prophylaxis is? So they get the infection, you treat it, and then you put them on a secondary prophylaxis to prevent them from getting it again, right? Because again, unless their CD4 count rises up above that threshold, they're still at risk for getting that infection once again, right? And so this is going to include a lot of different things. Back in the day, this used to be the thing that actually killed the patients most frequently, and if you don't have that CD4 under control, again, this can be pretty life-threatening, right? So you can start to see here that as they get down below things like, level 200 or so, this is where things like pneumocystis jirovecii comes into play. Obviously, oral candidiasis can be a big thing. If you think about someone who presents with thrush, you want to think about, well, why are they getting that thrush, right? So most immunocompetent individuals shouldn't have to worry about that, but who might be at risk for it? Well, they have HIV/AIDS, right? What else? Yeah, diabetes. Okay, that's a good one. What else? They have like maybe they're receiving chemotherapy and they're immunocompromised because of that. Anyone remember what drugs can do it? Which type of steroids? Inhaled corticosteroids, remember, that we use for asthma. It's a big thing you want to think about. So if you have someone who had thrush, you can ask those kind of questions. Okay, like what are your comorbid conditions? What medications do you take? If they're like, oh yeah, I take Flovent for my asthma. That kind of clues you in right there. You don't want to necessarily jump to, oh, you must have HIV, because again, you don't want to make that assumption about people when they don't have it. It can be problematic, right? So anyway, so again, several different things here. I'm not going to talk about every single one of these, but some of the more common things you're going to run into with these patients I will make mention of. And some of this does apply back to patients receiving chemotherapy, and we do this a lot for our patients over at Nemours. So I see a lot of patients on a lot of this chemo prophylaxis here. So as I mentioned, our goals here are to try to help to keep that CD4 count up as high as we can, hopefully to prevent those opportunistic infections from actually taking hold. If we can, we'd like to do things like vaccinate, especially when they have an intact immune system, because again, you need that immune system around to actually work with the vaccine. We'll talk much more about that in the next section, the next class period that we have. We'll talk about vaccinations. As we mentioned, once they get down below a certain CD4 threshold, that's when you're going to start up that chemo prophylaxis. And again, I'm not going to have you memorize every single cutoff for those, but make sure you look it up, right? So if you have a patient, you're evaluating them, and their CD4 is 50, go look at those guidelines. I'll look to see what should be recommended for them from a chemoprophylaxis standpoint, right? And then usually once they have a sustained sort of recovery in their CD4, then you can take them off the prophylaxis. So for instance, we'll talk about PJP here in just a second, but once they get down below 200, we'll normally start them up on Bactrim, and then once they're sustained above 200, maybe we start them up on a new regimen of heart therapy, then we can go ahead and cut it off. They don't have to be on that lifetime by any means. And again, not all inclusive, and the guidelines do change, especially as resistance patterns change. And so again, always, if you're interested, go back and check out the AIDSinfo.gov there. Okay. Now, what's interesting is one thing to consider here as well is that these patients who may have, say, long-standing HIV, they may have never been actually diagnosed with it, right? So say if you have someone who didn't have good access to medical care, or they just never went to the doctor, or they've had this infection for a while, you can imagine someone, maybe IV drug abusers or someone like that. They might already have some of these opportunistic infections already established, and so that's one of the things you have to kind of consider there. Be careful when you're mix and matching these drugs, especially with the heart therapy, because we saw, especially with things like the protease inhibitors, what kind of drug interactions could those lead to? Or some of those are actually intended drug interactions we're shooting for. We talked about like ritonavir and cobicistat. Those are actually inhibiting CYP3A4. We're using that to boost levels. Well, that can affect other drugs as well. Or for instance, if you're treating a patient for TB and they're on rifampin, what's that going to do? It's going to induce CYP3A4, and that's going to drive down levels of other drugs that could be interacting here, right? So these are all things you have to consider. And especially if you have someone who you're treating for opportunistic infection and starting them up on at least 3 meds for heart therapy, it can be kind of tough. It can be overwhelming from that standpoint. And again, they're going to probably feel worse before they actually feel better, because one of the things you can actually develop here is this immune reconstitution syndrome, or this IRIS is what it is. And basically, it's when you have the immune system start to kind of recover a little bit. Now all of a sudden you have this new inflammation because it's now starting to attack that opportunistic infection, and so it may seem like they're getting worse when actually it's just that their immune system is coming back online and they're actually getting a little bit better, so to speak. But the patient will definitely feel worse. So it's one of the things to consider here. And again, it depends on which infections you actually have, but we'll look at some of these more common ones you'll run into. So PJP is the first one, and of course I have a typo up here because it used to be PCP pneumonia, but now it's PJP. This is kind of the new nomenclature here. This is the most common life-threatening opportunistic infection for these patients. Things like thrush certainly can happen at a higher threshold, but it's not as likely to be to develop like one of these invasive fungal infections. However, PJP though can be certainly life-threatening when these actually do occur. This is a fungus itself, but has some kind of protozoal sort of characteristics here. And note that me and you with healthy immune systems, we could be exposed to it all the time and not really have a problem because we can fight that off. But these patients are particularly at risk, especially when their CD4 count gets below 200. Or maybe if they have like a history of oropharyngeal candidiasis or thrush, they tend to be more susceptible to developing PJP pneumonias here. And again, very significant respiratory disease. The treatment itself when using this is actually going to be sulfamethoxazole trimethoprim or Bactrim is going to be the go-to drug here. This is going to be for both treatment and for prophylaxis, both primary and secondary prophylaxis here. Yes, sir.
What if they have a sulfa allergy?
If you have a sulfa allergy, we're going to have to look up an alternative, right? But again, for the most part, I just want to focus on the common stuff, but certainly it's a very important consideration. What are the allergies? If they had a sulfa allergy, there are backups. I believe we could use something like pentamidine. It's a good one. I'm not going to really cover that here, but it's interesting. We actually have some patients who are on prophylaxis, and so actually that's what we do for them. And so we have some of our chemotherapy patients who they will get the alternative pentamidine, either IV, or we can actually use a nebulized form of it as well, because this is a respiratory tract infection. We can give that inhaled, and that gets very nice high concentrations in the lungs without kind of exposing them to systemic drug there. But anyway, good question. So, and in fact, what you're going to find is that when you think about IV versus PO treatment, so there's some antibiotics that we may have IV forms available. We just don't really use it that frequently, either due to cost or just due to the administration issues. This is one of those cases where you actually will whip out IV Bactrim, and it's if you ever see IV Bactrim, that's usually a pretty sick patient, probably with a PJP pneumonia here. We just don't use it that frequently because there's some issues with administration. It's hard to get into solution. It's kind of a nasty drug to deal with from an IV standpoint. But we use that for 21 days. And you notice here, you think about a normal bacterial infection. How long do you treat it for? 7-10 days, maybe 14 days. Notice here the treatment times are going to be longer because, again, we can't rely on the patient's immune system to help us out fighting that infection. So we're going to be treating them for longer to make sure we actually have full eradication of the offending pathogen. So again, 21 days here. So again, long treatment time. And then usually we'll put them on prophylaxis with Bactrim once they get down below that 200 threshold there. And then we actually will give it thrice weekly. So if you ever see someone who's on Bactrim, say they're getting Bactrim, one double strength tablet twice a day on Monday, Wednesday, Friday, or if they're getting it Friday, Saturday, Sunday, whatever, 3 days, that's usually going to be for chemoprophylaxis, right? So again, we don't need full treatment levels in the system. We're just trying to give enough to make sure that any PJP that gets into the system is not going to get a foothold, essentially. So if you ever see that, that's what that's being used for. Candidiasis or thrush. Again, this is due to the opportunistic colonization of the Candida species there. It can lead to more invasive fungal infections, right? It could be fungal pneumonias, it could be fungal bacteremia, or it's fungemia. And so it can be pretty devastating here. So again, a lot of times we'll either give prophylaxis with something like nystatin. Nystatin is very nice. If you remember, we talked about it briefly before. What's kind of the benefit of using nystatin? You can swallow it. Why can you swallow it? You don't have to worry about systemic absorption. So that's the benefit here, is you don't have to worry about any systemic exposure, because again, you're just trying to get and treating it right there locally on the epithelial, on the actual mucosal tissue there. If it's more esophageal, it's probably not going to be as sufficient, so that's when we can use things like fluconazole can be used here. And again, depending on if it's more oral versus esophageal, you may need to shoot for a longer treatment duration, as the case may be. But nystatin is nice. We use that a lot for prophylaxis because they can either swish and spit or swish and swallow. It really doesn't matter. If you think about giving it to kids, if you have like a very young kid and you say, hey, swish and spit this, are they always going to be compliant with that instructions? No, my kid's getting into this like spitting phase, so she could probably do it, but a lot of times they just swallow it and don't think anything about it, right? If you can even get it in their mouths in the first place. Oftentimes they'll spit it right back out at you without ever getting a chance to swish it also. Depends on the kid. But again, for this one, there's no specific recommendations for primary prophylaxis like we saw with PJP, but oftentimes we'll just kind of treat as needed. We'll just kind of monitor. If you see that thrush starting to develop as white plaques in the back of the throat, that's something you definitely want to go ahead and start treating immediately. And like I said, nystatin's a good option there. Other things, which I'm not going to get fully into detail on here, but things like cryptococcal meningitis, toxoplasmosis, Mycobacterium avium complex, which is another mycoplasma that differentiates itself from TB. Lots of different things here that can be infected with, and it's important to look up these recommendations as far as what levels you need to start prophylaxing at, when you can stop prophylaxing them, they need secondary prophylaxis, whatever the case may be. Make sure to look at that AIDS info website because they're always going to have the most up-to-date info. Other things to consider, patients with HIV are starting to live for much longer. As we said, they are starting to deal with more of these chronic diseases as they get older, diabetes, heart disease, all these things. And so because of that, you have to start thinking about okay, well, what other medications they need to be on and how that might interact with their heart therapy, right? So you always want to make sure you're checking those drug interactions there. Other things they can develop are going to be this HIV nephropathy that can actually occur there, so that can be important, especially if any of their meds are renally eliminated. You want to make sure you're monitoring their creatinine clearance to see how that's altered over time and adjust those doses. And then, of course, looking out for things like cancer, they tend to be more at risk for certain types of cancer as they go on. So again, those are other things to consider. Again, always check for your drug interactions. Just double check. It takes 30 seconds to run it through an interaction checker, and you'll get a feel for it when you start to run those to see like which interactions are actually important that you want to take note of, and which ones you're like, I don't really care about that, right? Obviously, if anything comes up as a big red box, you should probably take note of that, right? Or if it says a big X or a D, like you want to take note of that sort of stuff, right? As far as interactions go, just make sure you check. Okay, now moving into sexually transmitted infections. Can I just tell you my STI story? I don't know if anyone knows, but I drive an STI. And my wife, I got the car. She's a pharmacist too. She says, "You're getting an STI?" I was like, "Yeah, you're going to come with me. We're going to get an STI together." She says, "I don't know about this." We get in the car, and there's a little button you can change the settings on the center differential. And anyone know what you abbreviate that to? C. diff, right? So then she gets in the car. She's like, "Great, the STI has a C. diff now?" Like, not good. Anyway, so you have to be careful with abbreviations, because there's one time where I was running, I was in an old neighborhood, and I was out running. It's a very rare occurrence for me to be doing that, but I was out running. I had headphones going on, loud music being played, and I see a guy in his garage. He also had an STI. And so if you know anything about Subaru people, like we like other Subaru people, and we'll usually flash our headlights at each other or wave or whatever. And so I saw this guy, and I had the music going. I was like, "Hey, nice car." He's like, "Thanks." And I go, "I have an STI." Not good to be shouting to the neighborhood where you live. So anyway, just keep in mind, abbreviations can mean different things to different people. But here we're going to talk about sexually transmitted infections. Now, is there a link between Subaru drivers and STIs? I have no idea. But based on some of the ones that I've seen before, I would, maybe, I don't know, we'll see. There definitely is a correlation to vaping. That I'm very sure, but I'm an exception to the rule. But anyway, so let's get into some of the common STIs you're going to run into. Gonorrhea is going to be a very common one you're going to see here. Now, in general, when you're talking about sexually transmitted infection, some of the caveats we're going to be shooting for here, or some of the treatment considerations, is do you want something that's going to take a long time to treat these patients? No, you want to shoot for kind of one and done sort of therapies here. So the things we're going to be looking for are things you can just give a single dose of, and that's going to be the best, right? Because why do we want just a single dose of the med? Ensured compliance, right? So if you have someone coming up to your clinic, or you have someone coming into the ER with one of these sexually transmitted infections, they have obviously been partaking in some activity that has led to them getting that infection. So you wonder about them getting into activities afterwards that could be spreading that to someone else. So if I have ensured compliance by just giving a single dose and I watch them take it, then you know they're compliant, right? If I have to give them 7 days of therapy and they have to go out to the pharmacy to go pick it up, and they're like, I'm not going to do that. You're less sure about that. So that's going to be one of the big benefits here to a lot of these drug therapies, is just a one and done sort of thing. That becomes less reliable once you get into talking about allergies and alternatives, which we'll mention a few here. And I do want you to know those, right? So know what the common things we're going to use to treat these STIs are, and then what the alternatives are going to be if they have allergy or something like that, right? So anyway, let's talk about Neisseria gonorrhea. Again, what you're going to find is there are a lot of people who are asymptomatic with this, and they tend to spread it to other individuals. And so that's one of the big problems here. Typically, who ends up becoming more symptomatic here? Women actually become more symptomatic. A lot of the guys end up being asymptomatic, but they can tend to spread it to others, which is one of the things you're going to see with that. So at least the complications there tend to be a little bit more pronounced in those females. But there could be some delay in seeking treatment here because, again, of the asymptomatic nature of it. But things like, having pelvic inflammatory disease, more systemic infections can develop here. Not only that, but patients who have gonorrhea, they tend to spread things like HIV a little bit more commonly. So other things you have to consider as well, right? So other communicable diseases here. Now treatment, and again, where are you going to go to for guideline recommendations for STIs? CDC, right? CDC is going to be your home for these kind of recommendations. Always good to know where you're getting your guidelines from, right? So for instance, if I need to know how to treat meningitis, where might I go find that? One of the actual guidelines, not just looking up in a reference book. So things you want to consider: the Infectious Disease Society of America. I go back to the organizations that are actually coming up with these guidelines in the first place, right? If I'm dealing with the pediatric specific disease, where am I going to look? Well, you might want to think about checking with the American Academy of Pediatrics, right? So think about the organizations who are getting involved with these disease states and who you might be looking for the guidelines with. For these particular types of infectious diseases, CDC is going to be your gold standard there. So you always go back and check to see what they're currently recommending, because especially with these, you're going to find that resistance patterns are going to change what the primary therapy is going to be moving forward. So anyway, so looking at this, with gonorrhea, they do recommend a single IM shot of ceftriaxone. What type of drug is ceftriaxone? Third generation cephalosporin. Good. So again, there's good broad coverage. Notice here the dose we're giving is not really that significant. I'm not going to ask you the dose on the test. Just know that typically when you think about like systemic infections, we're giving like a gram, maybe 2 grams for something like meningitis. We're giving a relatively low dose here. So nice thing is that you don't see a ton of resistance of gonorrhea to ceftriaxone, and so we just give a one-time IM shot, and they're generally good to go. Ensured compliance is the name of the game here. Now, what we saw is patients who were taking oral cephalosporins, they ended up finding a lack of efficacy, so that's why we go with the IM route, right? So you may see, especially if you're treating, what's the common co-infection you're normally treating along with gonorrhea? Chlamydia. What do you use to treat that? Anyone know? Azithromycin. How is that administered? Oral, right? So again, they may get some pushback to be like, well, why the heck are you giving me a shot, but then I can take this pill orally, or why can't I just take both of them orally, right? You want to have a good answer for them. So you don't want to be like, just cause. So the CDC told me, like, oh, well, actually, because of the IM, this works better, right? You can make sure I get it right into your system with this particular drug. So that's why we like to do that. As we mentioned, co-infection with chlamydia is going to be very, very common. So that's why we need something like azithromycin. Typically, you just give a 1 gram dose by mouth, and you're done, right? Pretty long half-life. That 1 gram dose is going to be good. Anyone know like a typical like starting dose for azithromycin is? If you're like, treating, say, for instance, like mycoplasma pneumonia. Yeah, usually 500, right? So we're giving a bigger dose. But instead of a 5-day course, we're just giving it as a one-time dose. So again, bigger dose, but a lot shorter duration treatment there. Now, if you need an alternative, you could not use azithromycin. That's where doxycycline can come into play. You're going to find doxy is going to be a good alternative to a lot of these infectious diseases here. However, note the negative here is we have to treat it for 7 days. 2 times daily for 7 days. Longer treatment duration, compliance is not going to be as ensured there in those cases. Now, if there is a cephalosporin allergy, we don't have a ton of good options there at that point. So what do you do when a patient comes in and they say, oh, I can't receive a cephalosporin, I have an allergy? You just say, okay, well, that sucks. You're stuck with gonorrhea, sorry. You should have made better life choice. No. Never ever say that to your patients, that's terrible. No judgments, right? No, you want to say, what kind of reaction did you have? They're like, I don't know. My mom told me I have it. What are you going to say? Mom's a liar, maybe. Maybe mom's a liar. Maybe mom was fibbing that time. So a lot of times what you can consider is like, one, go through the medical chart, right? A lot of times I'll have patients who will show up and they have, listed as a penicillin allergy or a cephalosporin allergy. I'll go through the chart and be like, oh, they've received Rocephin before. They've gotten it several times. Okay, I can go through and I know that since they've received it before and they handled it fine, I can do it again, right? So again, just because it says an allergy in the chart doesn't mean necessarily they cannot receive that drug, okay? So you do want to provide that documentation saying, okay, well, I know they've received it before. Everything's totally fine there, right? For instance, like in our electronic medical record system, we have like little drop-down boxes. So when you are prescribing a drug that is contraindicated based on that allergy, you have to make a little selection or say, well, why are you giving this when obviously there's an allergy cross-reaction? And you say, well, the patient has tolerated it in the past. Just by saying that shows documentation saying, yes, I've at least addressed it. I know that this allergy is listed, but I feel comfortable giving the drug anyway, right? So, yeah, you want to find out what the allergy was, figure out if they've ever received something similar before. Now, remember when I was kind of talking about the cross-reactivity between penicillins and cephalosporins, if they have a true blue penicillin allergy, what's the cross-reactivity rate? Less than 1%, right? So they're very unlikely to have a true reaction to ceftriaxone, right? And again, this is just a one-time dose. So, and sometimes people do not feel comfortable doing this, but I like to go with the gusto, right? I say, well, let's go ahead and just give them a dose now. Let's do a test dose. If we're not really confident that's a true allergy, let's do a dose here. Because guess what? Especially if you're like in the ER getting treated, where would you rather have an allergic reaction? In the ER, right? The ER or the ICU, those are the 2 best places to have an allergic reaction because you got the epi right there. They can push it if they need to. So again, sometimes it takes a little bit of convincing, but we can say, well, listen, there's not really any good documentation here. Everything is very unlikely they're going to have a reaction. Let's go ahead and try it. Okay. Now, if they said, no, I received Rocephin before and I had to get epinephrine and I was intubated, at that point, what are you going to do? I'll probably use something else, right? So that's where things like something like gemifloxacin, which is a fluoroquinolone we don't use too commonly, can be used potentially. IM gentamicin, that's where the guidelines are going to be useful, right? So you can go back to the CDC, look it up, and be like, okay, well, if I can't use this, what are my good alternatives, right? Check out UpToDate, check out other references to see what could be some good alternatives there. And then one thing to consider as well is for infants who may have received it from the birth canal is we will sometimes use topical erythromycin. That can actually be used to make sure we don't get any kind of gonorrhea infections in the eye, and so that's where the topical erythromycin can be used, right? And again, the benefit with topical use is what? Really high concentrations, you know, so you don't have to necessarily worry about resistance so much, you know, so topical erythromycin is a very good option for that. With chlamydia, this is probably the second most frequently reported STD behind HPV. And so what you end up finding, though, is a lot of this is underreported too, right? So you're going to find that people who are asymptomatic may not be as likely to be presenting for treatment. So again, a lot of underreporting does happen in these cases here. As far as treatment goes, as I mentioned, azithromycin is going to be a good first-line option for that. Doxy can be a good alternative, but there's no short course for that. You have to get the full 7 days, which is unfortunate. And then again here, you kind of get double duty with the erythromycin because they can treat both chlamydia and gonorrhea for those infants and make sure they prevent any kind of eye infections. Okay, moving on to syphilis. What are you going to use for this? Good old penicillin, right? Good old easy penicillin. Very, very effective for this. Again, something we don't find a ton of resistance to has been developing over time here. Now, again, syphilis can be very, very dangerous if not caught and treated early because you can develop things like neurosyphilis, can be disabling or fatal. So really careful with that. So we want to make sure we're treating early. So we're going to need parenteral penicillin G. Again, parenteral just means what? Some sort of injectable, right? You know, IV, IM, etc. Now what you're going to find is that we don't really like to use short-acting meds or any kind of single doses here because it kind of reproduces fairly slowly. You're going to find that it's not really going to be all that effective, right? You'd have to have kind of more longer duration of treatment here. So what do I do to get around that? Well, I can give a long-acting injectable form of penicillin, which is your bicillin, right? It's that benzathine penicillin G, very, very effective. It's another intramuscular dose. If you remember, if I showed you a picture of it several semesters ago, but it looks like kind of a milky sort of solution there. So it's in an oil base. When you inject it intramuscularly, it kind of slowly leach into the systemic circulation and able to treat that infection. That's why it says bicillin LA for long acting. So that's a good single dose sort of option there. As an alternative, they did have a true penicillin allergy and they could not receive it. This is where something like doxy or tetracycline, say for 2 to 4 weeks or so, is going to be effective here. But again, longer treatment duration, less likely for patients to be truly compliant, and it could be having a recurrent infection or it could be spreading over to someone else. Okay. In cases where we have things like more systemic infections or like neurosyphilis, this is where we can actually use aqueous penicillin G. That's the typical IV form of penicillin G we're going to be using there. Anyone remember what else you might use like IV penicillin G for? Like a cardiac condition, endocarditis. Yeah, so you don't see a ton of IV penicillin being used out there in the inpatient side of things. If you do see it, typically it's either for endocarditis or it could be for something like a neurosyphilis or more kind of systemic syphilis infection. Typically, because again, what's the problem with penicillin G? Is that very wide spectrum? Is it pretty narrow? Fairly narrow, right? So again, when you're using empiric treatment for infections, if you don't have the actual bug sort of cultured out already, you're going to be going more broad spectrum sort of drugs there. That's why we like things like ceftriaxone, azithromycin, fluoroquinolones. So if you see IV penicillin G, either they've cultured something out that says like, yeah, this is specifically susceptible to it, or it's endocarditis or syphilis typically. So just so you kind of get a feel for it, you're normally going to see that. Moving on to genital herpes, again, this is going to be another fairly common thing you're going to run into. Typically, HSV1 causes more oropharyngeal disease, HSV2 causes more genital disease, but certainly they can flip depending on the patient there. Now, again, what's the main problem with this? Do patients, are they always symptomatic when they're spreading it? Right, they can still shed with that. And anyone remember like when like Valtrex commercials first started coming out? I remember being relatively young, but I remember just like on network TV, you'd see like these commercials of Valtrex all the time. And the only thing I remember from it is that you can still spread it even if you don't have any signs of infection. I was like, okay, that's scary. I'm definitely never going to get herpes if I can avoid it, right? Knock on wood. But again, just like, you know, if you remember seeing those erectile dysfunction commercials, what do you remember from those commercials? I guess they play golf. What was it? Yeah, they're going. If you have an erection for more than 4 hours, make sure you call your doctor, right? Yeah. So little things like that always get stuck in your head for whatever reasons. I guess the marketing does work, right? Because it's been ingrained in my brain for this long. Anyway, but yes, you want to make sure identify it, make sure we can treat it early. Typically, what's kind of the mantra as far as like starting treatment for viral illnesses? The earlier you can start, the better, right? So as soon as symptom onset occurs, you want to get that started as soon as possible. Just like for the flu, within 48 hours here as well. So again, starting it early means you're going to be able to kind of hopefully shorten the duration of the exacerbations. You're hopefully going to decrease their symptoms, make it a little bit more comfortable for them, etc. So again, what you're going to find though is because this is a recurrent disease that some patients are better with more sort of episodic sort of therapy. So they're going to take it around their exacerbations. So again, they should be educated on taking it as soon as they start to notice onset of symptoms. And then in other cases, we're going to find they're going to have chronic suppressive therapy. Chronic suppressive therapy hopefully is going to decrease the total number of outbreaks they have by taking sort of all the way around. What do you think would be the detriment of using kind of chronic suppression therapy? Just taking it when you're having an outbreak. More likely to see side effects, right? So again, if you're taking a drug every single day, you're more likely to see the side effects that can develop there. You have to think about things like, the clearance of the drug, whether a patient has renal disease or not. Anyone remember what drugs are going to use for this off the top of their head? Acyclovir, valacyclovir, those are going to be the two most common things we're going to be running into there, right? Don't forget, good hygiene can help to prevent things like super infections, right? So again, these typically are going to be uncomfortable, they can be itchy. So again, you can't see the secondary infections there, so good hygiene is really important. We don't have something bacterial on top of the viral disease. So our recommendations here, typically acyclovir and valacyclovir. Anyone remember the relationship between those two? Valacyclovir is a prodrug, right? It's actually the inactive form, but what's the benefit of giving a prodrug like that? It's better bioavailability, right? So that way when it goes to the liver and causes that first pass to occur, we actually get better bioavailability because it actually gets activated there in the liver. So valacyclovir does turn into acyclovir, but you're going to find the dosing changes based off the fact that it has better bioavailability. You typically give it less frequently, which is going to be good, again, from a compliance sort of standpoint there. Again, early treatment is better. So in some cases, you may give them a prescription for as needed sort of treatment. So say, take this for, once a day for 5 to 7 days at sign of outbreak, several refills. Or like as I mentioned, we may do the more kind of chronic suppression therapy where they take it every single day. And again, here you're going to find that typically topical treatment is not going to be recommended. We do have topical acyclovir products, but this is not going to be as effective here. And then other things to consider as well is going to be if they have immunocompromisation. So if they have, like, say, HIV on top of this, or they have receiving chemotherapy or something like that. Typically, you're going to see more disseminated disease. You can also see things like herpes encephalitis that can develop from this. It can be very, very nasty. I remember seeing one patient in the PEDS ICU. This is several years ago when I was on rotations. There's a patient who had a leukemia who ended up receiving a bone marrow transplant. When they get the bone marrow transplant, how do you prevent the body from rejecting the transplanted tissue? You got to suppress the immune system, right? So this girl was on all this different immunosuppressants. She's on tacrolimus. She's on corticosteroids. And so again, when you're suppressing the immune system that much, what happens? You get the secondary infections, right? So she ended up developing this herpes encephalitis. I think it was a herpes encephalitis. It could have been another virus. But anyway, we ended up finding that she had a very treatment-resistant sort of CNS infection there that by the time you end up seeing the CT scans towards the end of her life, you saw that it looked like, moths had been picking at the brain or something because of just all the degradation of that tissue that happened there. Very, very sad case. But again, think about the secondary complications of the drugs we're giving these patients and how we have other things we have to give them more drugs for on top of that. We ended up having to use things like foscarnet and all kinds of weird antivirals in order to treat that. And unfortunately, she ended up dying eventually. But very sort of sad case when you see this. But she happened to be at increased risk because of the fact that she was on all these immunosuppressants. We did that to her, but it was in order to treat the leukemia that she had originally presented with. But again, be careful with acyclovir and valacyclovir. Typically, it can cause some bone marrow suppression, which again, if they're immunocompromised, can be problematic. Make sure you're checking the renal function, make sure they're clearing it well, because otherwise you can get that crystal urea that can develop there, and look for CNS toxicity. As I mentioned, you can have episodic therapy. Typically, once they have these kind of prodromal symptoms sort of start up within 6 to 12 hours, they should go ahead and start therapy there, and typically be treating it over the course of several days there. They typically find it's going to be better for patients with maybe like more severe symptoms or prolonged recurrence. They tend to do a little bit better with this. However, when they're not taking it, they can still shed the virus, right? So again, if they have a partner who does not have HSV, they could potentially be spreading it to them. However, with chronic suppressive therapy, you tend to have less of that asymptomatic viral shedding, so you may be less likely to spread it. However, I don't know if there's enough studies out there to say specifically it's going to be 100%, right? So you still do recommend prophylaxis and whatnot. Okay, next up with trichomoniasis. So this is going to be more commonly in women that gets reported here. However, men often are asymptomatic, so they tend to spread it without knowing they're even spreading it here. Things to note with this one is it's a protozoa, so the treatment's going to be a little different, which means we're going to be using metronidazole. Now, what do we typically use metronidazole for before? You use it for C. diff, absolutely. Nowadays, it's starting to become more of a second-line agent for C. diff because they're starting to see more resistance. Now, instead, what would you use as a first line? Vancomycin, right? What type of vancomycin? What route? IV vancomycin? You're not going to treat that. I'm going to treat C. diff with that IV vancomycin. You got to do PO vancomycin, right? I could use IV metronidazole or PO metronidazole, but you can only use PO vancomycin for C. diff. So there's that. What else do we use metronidazole for? What did it cover? Anaerobes, yeah, we use it a lot for gut anaerobes particularly, right? So again, kind of one of those things I always like think about is normally when you think about anaerobic coverage. If I think of above the diaphragm, I think clindamycin. If I think below the diaphragm, I think metronidazole. As a general rule of thumb, that'll serve you somewhat well. But yeah, so we use this a lot for prophylaxis in patients with complicated appendicitis. So if they're coming into the ER, they're going to be going for an appendectomy. We'll oftentimes start them up on Rocephin and metronidazole. Metronidazole for the anaerobes, and then the Rocephin for what? What else resides in the gut? A lot of gram-negative stuff, right? So again, E. coli, Enterobacteriaceae, all those things. So again, we give the Rocephin for the gram-negatives, and then we give the metronidazole for the anaerobes there, right? So anyway, so looking at trichomoniasis, we're going to treat this with metronidazole or Flagyl. Now, what's the big thing you want to educate patients on when they're taking Flagyl? Don't drink alcohol with it. Why don't you drink alcohol with it? Disulfiram reaction. What is a disulfiram reaction? Red, hot, flushing, itchy, very uncomfortable, right? So again, as a theoretical concern, you know how many times I've ever seen it? I've never seen it. Doesn't mean it doesn't happen. It could happen, and some patients may be more prone to that than others, right? We do know some patients do have a relative lack of a certain enzyme, the acetaldehyde dehydrogenase. It kind of causes the same thing. But anyway, so metronidazole is there. There's another one called tenidazole, which is going to be working similar to metronidazole. They kind of fall in the same family. Now, if you have an allergy to one, typically going to have some cross-reactivity with the other one as well. And then also the same disulfiram reaction can happen with both of these. So just make note of that. Either of them, you typically give a 2-gram dose as a one-time dose, and they're kind of done, which is nice. So again, give a one-time dose. It's a lot bigger dose than you usually would see for other indications, but then they're kind of one and done at that point. And then typically we end up also treating their partners as well. And there's actually a law that was done relatively recently, in the past few years or so, where you don't actually have to even see the partner. You can actually write a prescription for them, sight unseen, to make sure that they get their treatment as well. And that way they can get filled at the pharmacy, they can take it, and then that way you don't have to worry about them spreading potentially either back to your original patient or spreading off to someone else, right? Okay, so any questions on those? The last little bit here is going to be mainly focused on hepatitis. You guys okay if I just go straight through? Yeah, I figured you would be. So 3 varieties of hepatitis. What are they? A, B, and C. Is anyone watch Rick and Morty by any chance? I always love the what's the park name? It's the dress Anatomy Park. Yeah, I always like the renditions of hepatitis in there. It was like C was like the good guy or something. Anyway, you can watch it. It's very funny. Very inappropriate, actually. Actually, don't go watch it, but very funny. Anyway, so hepatitis A, B, and C, you're going to find that C is probably the biggest one that's had some big treatment changes within the past few years or so. Which ones do we have vaccines for? A and B, right? So most people have probably been vaccinated for A and B. As far as recovery from these, are any of these lifelong illnesses? Used to be C. C used to be a lifelong illness, but nowadays we actually have definitive curative treatment, which is actually a big change. That's one of the things we're going to focus on here. We have new classes of antiviral drugs. They're actually going to be used to cure hepatitis C, so it's kind of a big change there. Anyway, hepatitis A typically, very rarely is it fatal. Typically, it's going to be pretty self-limiting for the most part. We do have a decreased incidence due to vaccination. That's not routinely done. However, you do see when it does happen, a lot of fecal-oral transmission and whatnot. Typically, does this require a whole lot of treatment? Nothing beyond supportive care for the most part, right? The big thing we're going to be focusing on is patients who are immunocompromised who may not be able to clear this on their own. Those patients may require some special treatment as we're going to see here. As I mentioned, most individuals end up resolving certainly by 6 months, but a lot of them resolve within 2 months without any kind of intervention whatsoever, right? So it's going to be good, but obviously the goals here, you can have normalization of liver function, decreased transmission. That's always going to be beneficial. So of course, wash your hands. It's going to be one of the biggest things to prevent spread there. As I mentioned, there's going to be a few different vaccines that are here. We're going to talk much more about vaccines in the next section, so I'm not going to kind of belabor this point, but just know that hepatitis A does have a vaccine. It's obviously going to be the best form of prevention there, right? And we actually recommend this one at 12 months. So again, they may have that first year of life or so where they're going to be at risk, but then at 12 months, in fact, I think my daughter actually needs her 12-month appointment, even though she's coming up on 13 months. So again, bad parents, but hopefully DCF doesn't use this against me in the court later. But so again, don't have to memorize the specific brand names for the vaccines you're getting for hepatitis A. Just know there is one. Know that that it's causing a lot of decreased incidence because of that routine vaccination. Now the other big thing to consider here as well, if you have patients who are either at the extremes of age, so if you had like say a 3-month-old to pick this up, or say you had like a 90-year-old who picked this up, they may be less likely to be able to really fight off that infection there. Or if they're immunocompromised, they obviously will not be able to do so. So in that case, we actually have a hepatitis A immunoglobulin. Okay, so basically it's immunoglobulin. Where do we normally get our immunoglobulins from? Usually from donations, right? So again, you go to donate blood or donate plasma, like that's where we can actually spin down those immunoglobulins. We can actually have immunoglobulins against A specifically. We'll also isolate those out. And so again, very expensive, very hard to get, but we can actually administer it to these patients. May not be able to fight it off on their own. Okay, so again, whenever you have something coming from donations, what do you have to consider? Are all patients going to be willing to accept that? No, you have to consider, especially things like Jehovah's Witnesses and whatnot. So consider the religious backgrounds, because if you accidentally give one of these products without their consent, like that can be a big problem, right? So again, they're going to not be too happy with you. Looking at hepatitis B, this is actually very, very highly infectious. Actually, an interesting fact, 50 to 100 times more infectious than HIV, so very easy to spread here. However, we do have a vaccine against it, so a lot of people are going to be protected from it. In fact, it's one of the first vaccines you're going to get as soon as you're born, which is good, so it provides some early coverage there. And again, you're going to find that some patients may not, if they do get hepatitis B, a lot of them tend to clear it on their own. But you may have some patients who are going to have persistent infection, that have these kind of persistent antigen levels greater than 6 months. Those tend to have more of chronic illness at that point. We find this more frequently in the perinatal infections, which is why we like to vaccinate against that as soon as the kid's born, or at least within that first day or so, hopefully to prevent any sort of transmission. So, again, what we're seeing here is that HBV is actually one of the first vaccines we have that actually could be shown to prevent cancers from actually occurring here. There's going to be some hepatic cancers that are prevented by the actual vaccine itself. There's a few different varieties that are available here. Now, keep in mind, we'll talk about vaccines a little bit later, but can you just give a single dose of a vaccine for every single one of them? Now, a lot of times you need a series of vaccines or series of shots. Why is that? We talk about the durability of response to these things. So again, how long do you retain that protection after receiving that dose of the vaccine? A durable response means it's going to be sticking around for a very long time, right? Less durable responses mean they're not going to be protected for as long, right? So again, if you ever, I don't think you have to do it for school, but if you ever go to work in a hospital somewhere like that, one of the titers they're going to draw on you is what? You check your Hep B titers, right? They want to make sure you still have protection against that, and if not, they're going to give you what? They give you a booster, right? They'll give you a booster shot to try to stimulate your immune system again against hepatitis B, so that way you prevent it from getting spread over to your patients potentially, or you get it from the patients, as the case may be. So by doing it by over 3 doses spread apart, you're going to hopefully kind of re-challenge the immune system every time, and you get a better durable response out of that. Now, if we have someone who has chronic hepatitis B and they're not going to be able to clear it on their own, one of the things we want to do is to try to maintain that viral suppression here. And ideally, if we can, we like to have the seroconversion, we have the loss of the antigen, and they're going to have the presence of this anti-Hep B antigen there, right? And so again, hopefully preventing the hepatic complications that come about from that, specifically like cancers and kind of chronic hepatic dysfunction in the long term. And again, the question, who should receive treatment? Oftentimes what you can do is actually just serial monitoring, kind of a watchful waiting sort of approach there, and looking to see what their serological markers look like, see what their hepatic function is doing by looking at the transaminases and whatnot. And then based off of the potential risk for developing morbidity and mortality related back to the liver, that's when you decide to kind of treat at that point. Now, I'll just give you an idea what a sample algorithm might look like when you're making this decision. So for instance, if you're looking at the actual hepatitis B antigen, greater than 20,000 units per ml. That's actual the antigen level in the blood, and then looking at the ALT, if it's greater than 2 times the, what's the ULN? What does that stands for? It's the upper limit of normal. So again, if you consider like say normal ALT, maybe 0 to 30 something, depending on the lab you're looking at, if it's 2 times above that, then that would be maybe that cut point for treatment. You decide, okay, let's go ahead and start treating it. Otherwise, you could just do this kind of monitoring, observe, see how the hepatic function is progressing over time. Okay, and we'll get into the drugs we're going to use here in just a second. So the first one we have up is this interferon. Anyone remember how interferon works? Talked about it briefly. We mentioned it in what other disease states? MS was one of them. What else? Certain types of cancer, we might also use this as well. So we use PEG interferon sometimes for certain types of cancer. But interferon, again, this is an immunomodulator, which is just meaning it's going to be stimulating the immune system to try to fight off the virus itself, right? Oftentimes we'll end up using a pegylated form, which Pegasus is the brand name for that one. Whoever thought of that, genius. But it's a lot better efficacy, and actually only using kind of once weekly injections, so it has a little bit longer duration of action. That PEG is just meaning it has basically the molecule to add onto the drug to help with the half-life and extending that out. But again, it's basically stimulating the immune system, try to mount the defense against the HBV. You can see here, it's a protein, so it's going to require injections. Again, the regular form 3 times weekly, just not really convenient. So that's why I like the pegylated form a little better. Again, cost, what do you think? Very expensive. Actually, all the treatments here we're going to be looking at for the most part for hepatitis B and C, super expensive. And I'll show you some of the cost for some of the new ones we have here in just a little bit for hepatitis C. Now, what other sort of effects can we expect to see from the interferon? Anyone remember? Mood change is kind of the most notable thing to me, right? And there's actually black box warnings on some of these for some of the neuropsychiatric events that can be precipitated by interferon. Suicide ideation, depression, aggression, all sorts of things can develop from this. Not only that, but also because you're stimulating the immune system, like you're going to be stimulating it and causing inflammation, so you get that flu-like sort of illness, right? So myalgias, a little bit of low-grade fever, etc. Those are big things to watch out for. And again, notice the black box warnings here. You can induce autoimmune conditions. It can induce infection potentially. So just be aware of that. Okay. Don't like to use it too frequently, but it is one notable drug that can be used for hepatitis B. And again, it's used it for quite a while, maybe even up to 24 months for some of these patients for them to seroconvert to not having the antigen anymore. So again, that's a long time. Other things we can use potentially include things like lamivudine. Anyone remember where we saw this? It's actually back in the HIV section. So if you look there, it's an NRTI, a nucleoside reverse transcriptase inhibitor. It actually has some cross-reactivity against HBV. It is not first-line treatment, but it could be used as an alternative potentially. And actually, in some cases, it can be given indefinitely. It's an oral tablet, so it's a lot easier from an administration standpoint. But just know that things like relapse and resistance are a pretty big problem with that one, which is why we don't like it first line. Other ones include idefovir. This is actually similar to lamivudine, which is another NRTI we talked about previously that has some activity here. This one you do want to note that it causes nephrotoxicity, so you do want to watch for renal function, make sure that's not worsening on you as time goes on. And then we have entecavir, which is going to be used typically for lamivudine resistant strains. So again, if you had a resistant strain of HBV that came back, you could try using entecavir as an alternative. Pretty similar safety to lamivudine, as you saw on the previous slide. It could be considered first line for some strains of HBV, mainly due to the fact that it's pretty low resistance rates and is fairly well tolerated. Another one called talpivudine, and then tenofovir is another one. This is actually starting to become a little bit more first line. In a lot of cases of HBV, tenofovir, again, we saw back in HIV, so again, very similar toxicities, which you're going to see there, but nice, we have low resistance rates. So again, this is only for patients who you've kind of watching their antigen levels, you're watching their LFTs. Once they start to rise, that's when you consider starting treatment. Again, if you can hold off on using the interferon, that's always going to be beneficial because it's such a nasty sort of drug. If you can use something like tenofovir, a lot easier. It's an oral tablet. They can take it almost indefinitely. Okay, now moving over to hepatitis C is the last one we're going to talk about here. We're going to see that very, very common. And in fact, for a long time, we did not have good treatment for it. We had ways to suppress it, but no real ways to actually cure it here. But starting in 2013, therapies have evolved and we actually have a good way to actually cure this, which is great. Actually, I knew one person who actually got hepatitis C because they were actually born in a foreign country. They had, I believe they got like a shot at some point, and they were hospitalized or something, actually picked it up in the hospital. I believe it was like dirty needles or something like that. They ended up catching it and brought it over here. So they didn't diagnose it for a good long time. And then by the time they had it, he was having to utilize a lot of these suppressive therapies, which I'm going to talk about, and they're just terrible side effects. And then these new ones came out, and it just basically changed his life, because now all of a sudden, didn't have to worry about it anymore. It's a chronic disease. You don't have to worry about things like progressing to liver transplants. Awesome. But we're going to see, some of the costs associated with those are very expensive. But anywho, as I mentioned, most acute cases tend to go on to be chronic. A lot of people cannot clear this one on their own, so they tend to become more chronic illnesses, which is why it's kind of separated it from A and B for the most part. Now, the goals of therapy here, we'd like to eradicate. This is now the main goal we're going to be shooting for here, which means we have a virologic cure, and we're going to be shooting for having these non-detectable HCV RNA levels, right? And obviously, we'd like to prevent that progression onto, end-stage liver disease and other complications, hopefully staving off the need for getting a transplant for some of these patients here. And we're going to find that you have to do baseline testing to figure out what variant of HCV they have, and that will have to do guide treatment. I'll show you what that looks like in a few minutes. So previously, we used to have interferon therapy be the cornerstone of this. And we mentioned it's a nasty drug, it's an injectable, we don't like it, it's still very expensive. But nowadays, we're starting to use these oral regimens. That's the other benefit to the new group of drugs here, is they're all orally available. And we actually treat them for 12 to 24 weeks. And then they're basically done at that point, right? And just to note, here in the US, the most common subtypes you're going to be running into for hepatitis C, there's kind of 6 different variants here, 1 through 6. The more common ones you see here in the US is going to be 1A and 1B. We'll talk about why that's important to know the subtype in just a few minutes. So the new class of drugs we have are called the direct-acting antivirals, or DAA. The nice thing about these ones is that when you're actually producing the HCV virus itself, you're going to notice that it has a kind of a long string of proteins that have to be chopped up to get into their actual functional form here. And so by having an inhibitor, you're able to come in and actually prevent the formation of new viral RNA. So you kind of arrest the actual growth of further RNA there. So we're going to see some are going to be protease inhibitors that actually prevent the activity of actually chopping up this protein here, and some of them are actually going to work directly on the enzyme that prevents the further elongation of the RNA itself. So it kind of is similar to what we saw with HIV, how we have different drugs shooting for different targets, and how we can combine those in some cases to get better synergy. So, and I will say this is probably the most awkward set of drugs to say, so if I stumble over them, just know it's not because for lack of trying, it's just they're a very awkward set of syllables. So the first one is daclatisvir, or Declenza. These typically, and I'm not going to have you memorize which ones are effective for which subtypes. I just want you to note that not every one of these drugs is going to be good for every single subtype of HCV. So that's why you have to test for it beforehand to know which ones are going to be effective against which varieties, and that will guide your therapy. And I'll give you a table in just a little bit to show you how kind of complicated it can get. But this one's going to be effective against GT1 and 3. And basically, this one's working by preventing the viral RNA replication by binding to that NS5A. So that's one of the enzymes that was necessary to actually produce the new RNA. And so by directly distorting the structure of the protein, it can't work with the RNA anymore, and it cannot produce new virus. So that's the way that one's actually going to be working, by directly affecting the NS5A enzyme. Other big things here, you don't have to adjust for hepatic impairment or renal impairment, so you don't have to worry about dose adjustments, which is super convenient. Look at the adverse effects. Every drug has those adverse effects: nausea, vomiting, fatigue, like really well tolerated for the most part. However, we saw how long do you have to treat for? 12 to 24 weeks, so 3 to 6 months. It's about $20,000 a month. So you think, wow, that is super expensive. However, hospital stays are very expensive. Having a liver transplant is very expensive. So in a lot of cases, it makes a lot of fiscal sense in order to just treat for this for that 24 months, and then they're cured. You don't have to worry about it anymore, right? Because before they'd have to be on lifetime interferon therapy, ribavirin therapy. It's much more expensive in the long run. So just something to know. Next, we have a combination drug called ledipasvir and sofosbuvir. Again, very difficult syllables to put together. Harvoni, a lot easier to say, I would say. This one's going to work against 1, 4, 5, and 6. Again, just a different variety of variants of Hep C that's going to be working against. This one's working again on or at least the ledipasvir is working on the NS5A that blocks that viral replication. And then the sofosbuvir is actually a prodrug. It's going to be inhibiting NS5B RNA polymerase. So again, basically this is working as sort of a chain terminator, similar to a lot of the NRTIs we saw previously for HIV. We kind of bind into the DNA, prevent it from getting any longer, or the RNA in this case here. So by doing that, no more viral replication, no more virus can be spread. Again, you may see this one by itself, in and of itself, is $27,000 a month. Again, very well tolerated, but a combination here. And again, you don't need to know the cost for testing purposes. I just wanted to at least illustrate to you how expensive these meds are. Very expensive, but in the long run, it's going to be a lot more cheap than having to get a liver transplant, as I mentioned. Next, we have maprevir. This one's actually inhibiting the protease. So again, you have that long string of viral proteins that's not functional at that point. You have to chop it up before it can become functional. This prevents that. So this is similar to the protease inhibitors we saw back in HIV treatment there, right? So again, no functional proteins, no replication of the viral RNA. Again, very well tolerated, maybe a little bit of photosensitivity, some pruritus, not a big deal. Now this one cannot be used by itself, so oftentimes it's going to be either combined with sofosbuvir or it's going to be combined with patients who are getting interferon ribavirin therapy. We'll talk about ribavirin in just a few seconds, but in some cases, sometimes we still need to use these older drugs for more treatment-resistant forms of HCV. We have onbatasvir, which is going to be an NS5A inhibitor as well. And again, oftentimes given in combination with some of the other drugs like the protease inhibitor or paritaprevir. The interesting thing here is actually given with ritonavir, and that actually helps to boost levels of that paritaprevir. So again, another case where we're using that 3A4 inhibition to our benefit, try to boost levels of that drug and have maybe less frequent dosing, etc. And so you see the brand name there. In some cases, you're even given 3-drug combination here to try to get more treatment-resistant HCV effectively managed. Now, ribavirin is this last new drug we're going to talk about in this category here. This is an older one. This is what used to be used along with interferon for the chronic suppression therapy for HCV. Oftentimes, this one is being used as an adjuvant, or kind of an add-on drug, if you have really treatment-resistant HCV. So maybe someone who's been on treatment for a long time, they develop resistance. Sometimes you'll add this on to get like kind of a little extra oomph in the regimen to try to really get rid of the HCV there. And so this one's basically working to decrease the activity of this guanosine triphosphate. And so basically it's going to be helping to lead to this error catastrophe. So by kind of causing a lot of damage to the RNA, eventually causes basically that apoptosis of the virus itself, and also thought to be somewhat immunostimulatory. Now, side effects are going to be kind of similar to the interferon we saw here as well, where it had things like suicidal ideation, depression, insomnia. Not great, right? Again, it's a protein, so it has to be injectable. It's going to also be at risk for developing what sort of really emergent sort of condition? Anytime you're injecting a protein? Anaphylaxis, right? So again, it's going to be a risk with interferon. It's going to be a risk here as well. Just be aware of that, right? And in some cases, they actually develop a hemolytic anemia. Again, 10 to 13%, so definitely not that uncommon. And so you want to watch for their blood counts. Make sure they're not going to be, developing a new fatigue or pallor or anything like that. It could be signs of this hemolytic anemia, right? And then as well, this is a pregnancy category X. Again, this is a problem as well with patients with HCV who might be on ribavirin. Even if the guys are on it, they worry about getting patients pregnant because there could be some spread of the drug to the female. It could affect the fetus potentially. So this is another category X sort of drug. X means don't give it because there's weighing the risk versus the benefits is just not going to be good. It's going to have big problems there for the fetus. And in fact, they actually recommend that after even discontinuing the ribavirin for 6 months, use 2 forms of prophylaxis in order to prevent pregnancy, right? So use oral contraceptives plus, condoms, things like that, just because you really want to make sure you don't have a fetus that's accidentally exposed to the drug there. Okay, so as I mentioned, typically ribavirin is added on for patients who have really difficult to treat HCV or more treatment-resistant HCV strains there. And as I mentioned, PEG interferon is sometimes used, but it has definitely gone down since those direct-acting antivirals have come around. Okay, and as far as cirrhosis goes, for those patients who already developed that really significant hepatic dysfunction, it can be pretty difficult to achieve a good virologic response. So they may need more kind of long-acting or more longer forms of therapy there. And just know that some of these drugs do need to be adjusted based on liver function. So this is something you want to look up depending on kind of where they're at. They've had it for a good long time. Their liver function is kind of not great. Just make sure you don't need to adjust the dose at all. So patients with treatment experience means they may need longer treatment or they may need that ribavirin, again, to get that little extra boost in their regimen there. And then definitely consider doing that resistance testing for them. Let's see. For acute exposures, up to 50% of patients may spontaneously resolve hepatitis C within 6 months. In those cases, you may actually want to defer therapy until then, right? So again, due to the cost, due to the side effects of something like the ribavirin and whatnot, you may wait 6 months and then see if they've cleared it. If not, then you're going to go ahead and start treatment for them. And again, compliance is super important here, especially due to the cost of the medications, but any delay could be leading to resistance, could lead to failure of that therapy, so you got to make sure they're going to be very compliant. They need to make sure they get that medication every single month. If they stop, And you have to worry about that resistance popping up pretty quick there. And just to give you an idea of what the treatment is going to be looking like for these, you can see different options that are available between, like, say, 1A, 1B, 2, 3. Don't memorize this. I'm just trying to show you kind of how treatment changes based off the different subtypes you have. And then, for instance, if you have cirrhosis, you need to add on things like ribavirin, etc., in order to try to get sufficient therapy there. Any questions on that? Yes, sir.
You said that they might wait 6 months to start treatment
Mm-hmm.
C. What if you're exposed to hospital or getting they just want to start using it right away?
In those cases, they might give you, oftentimes, again, test the patient first to see if they have it. That's always going to be the first thing, but they may give you treatment initially. So post-exposure prophylaxis can be a little different than someone who may have got it through sexual transmission or needle use or something like that. So maybe one of those things where, actually, I'm not sure. I have to look up a regimen to see specifically what it is, but chances are they probably want to go ahead and treat you immediately with some post-exposure prophylaxis. So, any questions I can answer? And everyone's packing up and getting ready to study. Any questions about anything that I can answer for you? How many rows does a man have to walk down? 6 before he can come in? Let me check the